Am I audible now? Am I audible now? Thank you. Uh, are you having these dashboards on the screen, or do you have a full view of the presentation? Good morning, everybody. I'm sorry for the bit of delay. I was trying to set up this entire thing. Today we are going to I have a lecture on vesicular-bullous disorders in dermatology. This lecture was originally supposed to be taken by Dr. Bhattacharya sir, but he's unavailable. I am Dr. Shishobhan and I am taking the lecture on his behalf. So we'll begin right away. Vesicular-bullous disorders are actually a group of disorders which are defined by the presence of bullae or vesicles. The difference is just it's just a nominal difference based on size. Vesicles are fluid filled lesions which are less than 0.5 centimeter in diameter, and bullae are fluid filled lesions which are more than 0.5 centimeters in diameter. In common language we call them blisters, and these disorders can either be genetic or they can be acquired, and based on the level at which the blisters forms, that is, they form within the epidermis or at the dermoepidermal junction or elsewhere, they are classified. So here is the classification. Vesicular-bullous disorders, they can be either inherited, which are genetic blistering disorders, or acquired, which are also known as autoimmune blistering disorders. It is not necessary that all blistering disorders will be autoimmune, but most of them are. Now, first we'll talk about inherited or genetic blistering disorders, and they are grouped under this broad term, that is epidermolysis bullosa. They are all, this is a group of genetic skin disorders, that is, there is blister or blistering of the skin and mucosae. It is visible at birth or very soon afterwards, as happens in most genetic disorders, and they are known as mechanobullous disorders. The reason they're called mechanobullous is because the blisters form after trauma, that is, after some mechanical stimulus, and they are of three main types. Epidermolysis bullosa simplex, where the split is intraepidermal. Actually, it is in the stratum basale, the lowest part of the epidermis. Junctional epidermolysis bullosa, where the split is at the level of the basement membrane zone, and dystrophic epidermolysis bullosa, where the split is subepidermal, just underneath the basement membrane zone. So simplex, junctional, and dystrophic. The basement membrane zone is actually composed of four layers. The first layer is called, the first layer right here is called the hemidesmosome. The hemidesmosome has plaquins, plectin, BPAG1, and this BPAG1 is attached to alpha 6 beta 4 integrin, and this comes underneath the hemidesmosome, that is lamina lucida, also known as lamina rara. Okay, there is BPAG2 right here. BPAG2 is nothing but type 17 collagen. BPAG1 at the hemidesmosome and BPAG2 mainly in the lamina lucida, actually extending all the way from the hemidesmosome through the lamina lucida up to the next layer, that is lamina densa. Here we have other molecules, laminins, cadherins, connexins, and then these are the anchoring fibrils, which are made up of type 7 collagen, and this is sublamina densa. All right, so 4 layers: hemidesmosome, lamina lucida, lamina densa, followed by sublamina densa. 4 layers of the basement membrane zone. So first we'll talk about epidermolysis bullosa simplex. Now remember, epidermolysis bullosa simplex, we said that the split is intraepidermal, which is actually in the lowest layers, that is stratum basale of the epidermis. So the split is in this particular cell, the cell which is housing the hemidesmosome. These cells have keratin 5 and keratin 14 right here. So these mutations in keratin 5 and 14 result in bullae with basal cell within the basal cell keratinocytes, the onset of blistering over trauma prone sites at birth. So when the obstetrician is handling the baby or using forceps or something, then itself a blister will form. Now, since the blister is just epidermal, they will heal without scarring. Unless the basement membrane zone or the sublamina densa is damaged, there is no scarring. So mucosa, hair, and nails are spared. Junctional epidermolysis bullosa is due to mutations in laminin 5 and bullous pemphigoid antigen 2, PPAG2. These have an autosomal recessive inheritance and 2 forms: lethal, that is Hurlitz's type. You don't need to remember all the types. Just remember that junctional epidermolysis bullosa is actually a very lethal disease. Most children won't survive up to 5 or 7 years or more than that. Often it is accompanied by laryngeal stenosis. So they are present at birth or soon afterwards. There is severe skin fragility, extensive blistering and denudation. Teeth are malformed or prematurely lost, and nails may be shed. There is nail dystrophy. So junctional epidermolysis bullosa, the damage is somewhere right here, laminin 5 and BPAG2, these, lamina lucida. Next we come to dystrophic epidermolysis bullosa. So here we have collagen 7 mutations. The blisters form in the sublamina densa. Now once these blisters are forming in the sublamina densa or in the dermis, there will be scarring. So you see there's a deformity. The fingers don't appear to be separate. This is known as mitten hands and mitten feet. What happens because of repeated trauma in the interdigital areas, continuous friction, there are blisters forming since birth here, and every time blisters forms, there is scarring, and over years and years of this scarring, you see the skin appears so much scarred. Over years and years, they join together, adjacent fingers are joining. So this is known as mitten hand and feet deformity. So there is skin fragility and scarring with milia. Milia are basically blocked ducts of the eccrine glands. Once there is scarring at the level of the dermoepidermal junction, the secretion cannot come out. So they they form little uh, papules, very small, like 1 to 2 millimeter. They are visible on the scars as white papules. That is known as milia. The onset is again at birth or early infancy, and blistering of the skin mainly over trauma-prone sites. There are oral blisters and scarring, so there may be ankyloglossia and microstomia. Esophageal lesions are painful with dysphagia and strictures. Here too there may be uh, perianal blistering, erosions, scarring with stenosis and fecal retention. In eye, similar to the oral cavity, there is symblepharon and corneal opacities. Repeated blistering and progressive scarring leads to contractures and deformities. These are the genetic blistering disorders. So in this, the investigation consists of a skin biopsy, and which is available at most places, and electron microscopy to detect the level of split. Electron microscopy is not available at most places, so You can go for fluorescence overlay antigen mapping, in which we tag the antibodies against particular antigens, in this case like bullous pemphigoid antigen 2, BPAG2, or laminin 5, and we can see it's like an ELISA. We can detect whether these antigens are present in the skin or not. If the antigen is present, the antibody will attach and we can see the fluorescence. But if the antigen is not present, the antibody won't attach. We won't see the fluorescence. That means that particular molecule is absent. So that is how we can diagnose. That is known as fluorescence overlay antigen mapping. And immunohistochemistry, it's a similar process. The better way is to undergo prenatal DNA testing for couples at risk. Suppose one of them is having epidermolysis bullosa or a family history, or in case of autosomal recessive disorders. The treatment is, of course, avoidance of trauma, maintaining adequate hydration and nutrition, prevention of sepsis, care for the oral and ocular mucosa, and management of contractures and deformities. It's a very difficult disease to live with. I have seen many patients, and there are some who, of course, make it to adulthood and live a reasonably normal life. But it's a very difficult disease to live with. Now we come to the acquired or autoimmune blistering disorders. So you have to remember there are mainly two groups. So where the bulla is intraepidermal, and in cases where the bulla is subepidermal. The intraepidermal bulla is known as the diseases with the intraepidermal blisters are having this term pemphigus, which comes from the Greek word pemphix, which means blisters. And the subepidermal disorders are often clubbed together as pemphigoid group of disorders, right? So in the intraepidermal, we have mainly two forms, pemphigus foliaceus and pemphigus vulgaris. In the subepidermal type, we have bullous pemphigoid, then linear IgA disease, that is chronic bullous disease of childhood, dermatitis herpetiformis, and EBA, epidermolysis bullosa acquisita. We had epidermolysis bullosa, which was genetic since birth, and here we have epidermolysis bullosa acquisita, the word implying that it is acquired, not genetic. So this is pemphigus, derived from the Greek word pemphix, which means a blister or bubble, and it's a group of autoimmune disorders of skin and mucous membranes. Histologically, well, histologically we can see an intraepidermal blisters due to loss of cell-to-cell adhesion and separation of keratinocytes. We'll get to the mechanism how this happens. This is the immunopathology, how it is an autoimmune disorder, because in vivo the bound and circulating IgG autoantibodies are directed against epidermal cadherins, that is, which are calcium dependent cell to cell adhesion molecules. In this in the skin and mucous membranes, they are known as desmogleins, right? Desmogleins, which bind cells to each other. We have mainly desmoglein 1, 2, 3, and 4. In here, right here, we'll talk about desmoglein 1 and desmoglein 3. So there are, now we are still in the intraepidermal disorders, and pemphigus has many variants. First and foremost is pemphigus vulgaris, and it has a variant called pemphigus vegetans. Then is pemphigus foliaceus, and it has variants pemphigus herpetiformis, pemphigus erythematosus, and endemic pemphigus, also known as Fogo-selvagem. Then we have paraneoplastic pemphigus, drug-induced pemphigus, and intracellular IgA dermatosis, that is IgA pemphigus, and subcorneal SCPD, also known as subcorneal pustular dermatosis. In short, we call it SCPD. So pemphigus vulgaris is a disease of middle age. In India, actually, the age is found to be younger. In the West, it is generally right 50 to 60, but in India, it has been found to be around 30 to 40. Ashkenazis use are have increased susceptibility, and males and females are equally affected, though in our setup, we see mostly females. The target antigen is desmoglein 3. Actually, in few patients, desmoglein 1 is also the target antigen. We'll see desmoglein 3 is the molecule that is binding the cells in the basal and suprabasal layers of the epidermis. It would be wrong to say that it is strictly compartmentalized to basal and suprabasal layers. The relative amount of desmoglein decreases from the bottommost layer to the top, desmoglein 3, decreases from the bottommost layer to the topmost layer, right? So the stratum basale will have the maximum relative amount of desmoglein 3, and the stratum spinosum and the granular layer will have max a slightly less amount of desmoglein 3, but they have desmoglein 3 as well, right? While desmoglein 1 is found to be maximum at the top layers, and its amount decreases as we go down, right? In the mucosa, desmoglein 3 is expressed much more than desmoglein 1, very much more. So that will impact how this disease is present. Now, in case of pemphigus vulgaris, the target antigen is desmoglein 3. In case of mucosal dominant patients, desmoglein 3 is the only target antigen. In case of patients who present with both, that is both mucus and cutaneous disease, the antibodies are against both desmoglein 1 and desmoglein 3. In case of mucosal dominant disease, mainly desmoglein 3. But remember, desmoglein 3 is expressed everywhere, right? So whether if you have antigen against desmoglein 3, it is going to affect your mucosa also and your skin also, because desmoglein 3 is expressed only in the basal and is expressed in the skin, in basal and suprabasal layers of the epidermis, and it is strongly expressed in the mucosa also, right? So circulating IgG4 pemphigus autoantibodies will be binding to desmoglein 3 and 1 in case of, we'll just learn about it, found in desmosomes which are present on the keratinocyte cell membranes. Now neutrophils will come because of the binding of antibodies. They will release elastases and proteases and everything. Then there will be destruction of the desmosomes. So once the desmosomes are destroyed, these cells, mainly the stratum spinosum, stratum granulosums, the uh, Malpighian layers. Just a second. I'm presently on COVID duty too, and I'm having to manage that. Thank you. There is lysis. There is lysis of the intracellular cement substance, that is desmoglein. Once these cells are separated from each other, these cells lose their normal shape and become rounded. These cells are known as acantholytic cells. Right? These cells become rounded. We can see them right by preparing a smear, a Zhang smear. You can easily see these cells. These are known as acantholytic cells. And then there is formation of an intraepidermal blister. This blister cavity actually consists of many acantholytic cells. They are just floating around in the blister cavity. Once the cells separate, there is influx of water inside in the intercellular spaces. Not water exactly, serous fluid, and that leads to the formation of the blister. The binding, the intercellular cement substance is what is actually making that is actually maintaining the fluid dynamics of that particular space. Clinical features of pemphigus vulgaris. In all patients, there is painful erosions of the oral mucosa. Intact blisters are rare in the mucosa because these blisters are intraepidermal. They are fragile. The top layer is very fragile. They will just, if you chew, the lesion is going to just disappear, and there is going to be an erosion only. And more than 50% of the patients also develop flaccid blisters and widespread cutaneous erosions. The thin-walled flaccid bullae containing fluid which is initially clear, but later it may become hemorrhagic, turbid, seropurulent. The bullae will rupture easily to form painful raw surfaces. Pemphigus is a fatal disease. I have seen countless mortalities due to this disease. It is a fatal disease unless it is treated. It should never be ignored. Raw surfaces with tendency to spread, and it takes a very long time to heal. Generally, there is no scarring because it is intraepidermal, but once there is secondary infection, there is scarring. But with time, that scarring is very minimal, and with time, the outcome is very good. The sites are oral cavity, groins, genitals, axillae, scalp, face, and neck. Of course, eye can also be involved because mucosae are involved. So on the left, you have an image that is mucosal erosions of pemphigus vulgaris. You can see the nose is also involved. You can see the eyes are also involved. And on the right, you have flaccid bullae and erosions on the skin. This is actually a very minimal disease. Extensive disease leads to loss of skin from the entire back or body. Now we have this clinical signs of that are to be elicited in case of blistering disorder. First is the Nikolsky sign, that is lack of cohesion within the epidermis. Causes the skin's upper layers to be easily moved laterally. How we demonstrate this is by applying tangential pressure with some object that can have a grip, such as rubber. So you do a direct Nikolsky and an indirect Nikolsky. A direct Nikolsky is just applying tangential pressure on the skin at any site over a bony prominence. Now, if the patient is having very active disease, the antibodies will be there too, at that site too. And once you apply tangential pressure, the layers will slip off, and you will artificially create a bulla there. Quickly fluid fills and there's a bulla. There is an indirect Nikolsky sign in which you apply tangential pressure beside beside that particular beside a particular bulla, and if the blister is extending, that means the disease is active. Then you have a bulla spread sign or an Asbo-Hansen, also known as Asbo-Hansen. Actually, there is a slight difference. Bulla spread sign is for larger bullae, Asbo-Hansen is for very small bullae. Now, in bulla spread sign, if the bulla is large, first you draw the outline of the bulla on the skin, as it is seen here with blue ink. He has drawn the initial outline of the blister, and then apply pressure from one side. That is, try to push the fluid out. Now, if there is antibodies are already deposited in this particular area, these antibodies will be easily the molecules, the desmoglein molecules, are already gone, so the fluid will easily be pushed into this side. As you can see, the fluid has been pushed right here, and the blister is extending, the bulla is spreading, so it's known as bulla spread sign. In case of Asbo-Hansen sign, in case of a small blister, you apply the pressure directly from the top, because it's very difficult to apply it from one side. Now, this can be of course, I told you that it can be fatal due to secondary bacterial infections and fluid and electrolyte imbalance, and that is in fact what happens in cases where there is actually the disease is often resistant. I'll let you know later. Now, this is pemphigus vegetans, one of the variants of pemphigus vulgaris, in which vegetating plaques, vegetating lesions, that is lesions which spread very quickly, are formed on the flexural sites, such as here you can see it is a retroauricular region. It can form on the axillae, it can form in the groin, the intertriginous areas, that is of the scalp, face, and on the edges of this vegetation you have fungoid or papillomatous proliferation. If you can see the edges having papillomatous proliferations. The tongue has cerebriform like changes, that means it uh, happens to have a texture, and there are mainly two subtypes, the Neumann type and the Halopow type. Diagnosis can be made with a bedside test. This is the bedside test, Zhang smear. Acantholytic cell, large round cell with hyperchromatic nucleus and a perinuclear halo. It's a large round cell with a hyperchromatic nucleus and a perinuclear halo. It becomes round because now the desmogleins were helping it making take on a shape. It's kind of like if you take a handkerchief and you pull it from 4 different directions, the handkerchief will have that shape. But once you let it off, the handkerchief will assume its original shape, right? So once the adhesions are gone, they attain a circular round to oval shape due to peripheral condensation of the cytoplasm. Now, histopathology, you see a supravasal cleft with acantholytic cells in the cleft. Tombstone appearance is actually given to the name of the basal cells arranged in a layer, right? So they are like standing on the basement membrane, and above them there is nothing, just a fluid filled blister. So it appears like there are gravestones, like you have graves in a cemetery. So it looks like a tombstone, and you have very vascular infiltrate of lymphocytes and neutrophils, because that is ultimately what is the pathology. Now, this is another important test, immunofluorescence. It can give you a quick diagnosis. It hardly takes like 1 to 2 days for these reports to come. What happens is you look for which antibody is deposited at which site through uh, by using anti-IgG antibodies, which are tagged with fluorescent markers. So here you find intracellular IgG and C3, that is complement deposits, showing a fishnet or honeycomb pattern. Like all the like once all the cells are, see right here, the image is right here. You can see this is the Zhang smear, which is showing this rounded cell, acantholytic cell, and here you can see a suprabasal blister. So this is the epidermis, this upper layer, and here you can see it has split. Now this is the basal layer. So if you magnify this further, cells are arranged in a tombstone like appearance, and these are acantholytic cells just lying around in the blister cavity. Now remember, a DIF, that is a direct immunofluorescence sample, a biopsy for DIF should not be taken from the blister, because you will see nothing. The antibodies are gone, they have been destroyed by the neutrophil proteases. So take it from the perilesional area, somewhere around here, that where the antibody deposit is there, but the blister is not yet formed. So once you have done that and you have added the anti-IgG fluorescent tagged antibody, you can see it has gone and attached to all the IgG4 that is stuck to the desmogleins, and you can find a fishnet pattern, this particular pattern, fishnet. All right. Treatment of pemphigus vulgaris, the mainstay is steroids, but it can be given as a daily steroid or it can be given as a pulse steroid. Right? Pulse steroid means giving suprapharmacological dose of steroid. You will never see anybody giving dexamethasone 100 milligram on a day. You take dexamethasone 4 to 8 milligram maximum per day, but we give dexamethasone 100 milligram a day, which is 25 times that dose for 3 consecutive days. That is a very high dose. Or we can give methyl prednisolone 1000 milligram per day, even more. And then we have to give an immunosuppressant or a steroid sparing agent, which the patient will have to take, because the disease duration is very long. It takes almost 2 years for us to control the disease. Some might achieve a control within a very small time, within like 1 month or 2 months, but most of them have a recalcitrant disease. It takes 2 years almost to control. But beyond, the disease is not gone beyond 2 years, it is just controlled. It can occur anytime. Within next 10 years it can reappear. So we have to give them a steroid sparing agent along with steroid, such as cyclophosphamide or azathioprine or mycophenolate mofetil, or in some cases cyclosporin or methotrexate. We can give IVIG also, or dapsone, nicotinamide and tetracycline. These are slightly older therapies. Antimalarials, that is hydroxychloroquine sulfate, cyclosporin. Rituximab is an anti-CD20 monoclonal antibody, and it acts like a missile. It's a carpet bomb. It goes and bombs out all the plasma cells at once. Now if the plasma cells is gone, nobody is there to produce the antibodies. Within 3 months, it takes some time, but within 3 months the patient generally is rid of the antibodies. The only thing is, plasma cells are not producing antibodies only against desmoglein, they're producing antibodies against everything, and rituximab does not select which plasma cell it will attack. So for a long time you have so much depressed immunity that you are very susceptible to any infection, to any sepsis, any kind of sepsis. It's a very, very critical choice when you have to take rituximab. You have to be very careful. When you are going to choose rituximab for somebody, you have to be very careful. And once you have given rituximab, you cannot take it back. Pemphigus foliaceus is less severe than pemphigus vulgaris, and the patients are not severely ill. Actually it's an irritating disease. There are scaly, crusted cutaneous erosions, superficial erosions, because pemphigus foliaceus is antibody against desmoglein 1. And remember what I told you about desmoglein 1. We'll go back. Desmoglein 1 is found throughout the epidermis, but mostly in the upper layers. Now, it is, even though it is found throughout the epidermis, remember what is more in the lower epidermis. Desmoglein 3 is more. So even if I knock out desmoglein 1, desmoglein 3 is there to compensate for it, right? And in the mucosa, desmoglein 1 is not there at all. It is actually expressed very weakly. So it hardly affects, it never affects the mucosa. It is very rarely. Small blisters might form in the mucosa, small erosions. That too in patients with a severe high antibody load. In pemphigus foliaceus is rarely fatal and patients don't really die, but it's a very irritating disease. You keep on having these blisters, and sometimes they can be so extensive, it looks so bad. There is a tremendous psychological impact also on the patient. Now, because the vesicle is so superficial and fragile and ruptures easily, there is only crusted cutaneous erosions in a seborrheic distribution, that is face, scalp, and upper trunk. Now, they do not have clinically apparent mucosal involvement even with widespread disease, but sometimes we do see, and it may stay localized for years or may rapidly progress. And it's basically what I said, it's an irritating disease, may produce an erythrodermic exfoliative dermatitis. It occurs, that is, it becomes very red. The skin becomes red, up to 90% of the skin may be involved. Nikolsky sign is of course present, and on histology we see a subcorneal blisters with neutrophils forming in the blister cavity. On DIF, we see intercellular deposition of IgG4 against desmoglein 1. So here you can see the majority on the right side on the histopath. You see the majority of the epithelium is intact. Only the superficial layer, the corneum, this is the stratum corneum, that is separated, right? That is subcorneal. Okay, and this is the lesion that you see in pemphigus foliaceus. Pemphigus erythematosus is actually a variant. From the name, you can guess that it has to do something with SLE. So there is circulating anti-nuclear antibody also in these cases, and the patient has a malar rash. You can see here. So typically scaly and crusted lesions in the malar region and in other seborrheic areas. Oral mucosa is rarely involved, and immunologic features of both pemphigus and lupus erythematosus. That is, this IgG deposits in the keratinocytes. In SLE, there is granular IgG and C3 deposition on the dermoepidermal junction called as lupus band. So we can see a lupus band also in these cases, in addition to circulating ANA. So as it is associated with myasthenia gravis or thymoma. Pemphigus herpetiformis is a rare and atypical variant of pemphigus. I'm not sure whether you people need to know a lot about it. So I'll just let you know, it resembles dermatitis herpetiformis, which is why the name pemphigus herpetiformis, and widespread pruritic papules and vesicles will develop on an erythematous background. Most patients have a clinical variant of the pemphigus foliaceus, and remainder may have a variant of pemphigus vulgaris. There is eosinophilic spongiosis and subcorneal pustules without acantholysis. So IgG autoantibodies are directed against the cell surfaces of keratinocytes. The target antigen is desmoglein 1 in most cases and desmoglein 3 in others. So desmoglein 1 in most cases, the variant of pemphigus foliaceus, and desmoglein 3 variant of pemphigus vulgaris. Now this is important for you. There are PG entrance questions on this. Endemic pemphigus foliaceus, also known as Fogo salvagem or wildfire. It is endemic to certain parts of South America and generally to the sites of river basins. So it is because of the simulium fly. Okay, the simulium fly right here, black fly, Simulidae of the family Simulidae, and this fly, when it bites, it releases some antigens which mimic desmoglein. So there is formation of antibodies against those antigens due to molecular mimicry, and now these antigens go and attach to desmoglein 1, and there is formation of superficial blisters histologically, and that are histologically immunologically identical to pemphigus foliaceus. Now because this was just an one time event, just a one time event, that is the bite of the fly followed by this thing, it subsides quickly, and it may occur again. Okay, it's endemic, common in children and young adults. The initial lesions are flaccid bullae, Nikolsky sign is positive, head and neck are involved first. Burnt appearance and burning sensation. There is some blackening. The reason for the name Fogo salvagem, Portuguese language word for wildfire. Mucous membranes are not involved, of course, in pemphigus foliaceus also. The treatment of pemphigus foliaceus is again oral steroids, along with, here we can be slightly less aggressive in the treatment and try less toxic drugs. So dapsone is often tried because it is a less toxic drug and you can take it for a long time, unlike cyclophosphamide or azathioprine or ACQS and IVIG. ACQS2 can be taken for a long time. Now, drug-induced pemphigus is actually very rare, and particular with penicillamine and captopril. Now, penicillamine is not at all used nowadays. Captopril, of course, you know that too is not used. Now, with penicillamine, pemphigus foliaceus is seen more commonly than pemphigus vulgaris. And both penicillamine and captopril contain sulfhydryl groups that are speculated to interact with the sulfhydryl groups in desmoglein 1 and desmoglein 3. This may lead to auto-antibody production or may directly interfere with the adhesive function of the desmogleins. Most but not all patients with drug-induced pemphigus go into remission once the offending drug is discontinued. Now, paraneoplastic pemphigus generally comes in with patients of old age, and in this, the antibodies are formed not just against desmoglein but also against laminins, against other molecules, against you can have antibodies against uh, integrins, against uh, fibulins, against fibrillins. You can have antibodies against a large number of molecules. So what happens is uh, there is immunofluorescence demonstrated within the intraepidermal, within the epidermal region, like a fishnet pattern. But there is immunofluorescence in the basement membrane also. There is immunofluorescence under in the just underneath the basement membrane also because of antibodies to collagens, and this is commonly associated with neoplasms such as non-Hodgkin's lymphoma, chronic lymphocytic leukemia, Castleman's disease, malignant and benign thymomas. And the earliest presentation sign, actually, in fact, the most glaring sign that will stare in the face is intractable stomatitis. There is severe mucositis. It is resistant to therapy. And most patients have a severe pseudomembranous conjunctivitis, which may produce scarring. Esophageal, nasopharyngeal, vaginal, labial, and penile mucosal lesions may also be seen. Polymorphic cutaneous lesions, flaccid or tense bullae, and this is EMF. EMF means erythema multiforme, like palms and soles will be involved. Treatment is treatment of the neoplasia, otherwise it is refractory. Now IgA pemphigus is basically pemphigus but not IgG4 antibodies, IgA autoantibodies, okay, instead of IgG4, and it has two types, SCPD type and an intraepidermal neutrophilic type. Subcorneal pustular dermatitis, that is SCPD type. So in SCPD type, the IgA autoantibodies are against the upper epidermal surfaces. The name subcorneal, so upper. While in the intraepidermal, it is throughout the entire epidermis. Now, in either case, it will be flaccid vesicles or pustules coalescing to form an annular pattern with crusts in the center of the lesion. The common sites are axilla and groin. Mucosal membranes involvement is rare. Pruritus is a significant symptom. Now we'll come on to the pemphigoid group of disorders. If you remember, pemphigus is intraepidermal. Pemphigoid means the basement membrane or just underneath that. So most common it is bullous pemphigoid is a disease of elderly, usually 60 plus. It's a chronic disease with spontaneous exacerbations and remissions. It uh, actually it has more morbidity. Mortality is rare. Patients don't die, but it's actually a very irritating disease again. And the blisters make it difficult for you to sit, to handle things, to do anything. And painful, of course, because the subepidermal bulla and the dermis and everything is exposed. So the target antigen is BPAG1, or also known as BP230, that is 230 kilodalton molecular weight, and BPAG2. Both are the target antigens, and the antibodies are deposits of IgG, A, E, and complement along the basement membrane zone. So the pathogenesis is this: circulating anti-BP180 and anti-BP230 target antigens within the dermoepidermal junction. They activate the complement pathway and release chemoattractants, recruitment of eosinophils and neutrophils. Eosinophils because IL-13, IL-4 and 5 are also released. There is release of destructive proteolytic enzymes, and the basement membrane zone separates. A subepidermal blister is formed. The clinical features of bullous pemphigoid: there are cutaneous manifestations. For polymorphic lesions are formed. Initially, there is a non-bullous phase where just urticated lesions are formed, and the patient complains of pruritus. The patient can often have pruritus with urticaria like lesions for up to a year before blisters form. Once the blisters form, they are tense vesicles and bullae and contain clear fluid on normal erythema or erythematous base. On rupture, they form denuded areas with tendency to heal spontaneously. The Nikolsky sign is negative. It is difficult to extend these bullae, right? Nikolsky sign is negative in subepidermal blistering disorders. The sites are symmetrical distribution in lower abdomen, inner thighs, groins, and the associations are malignancy, diabetes, drugs to ulcerative colitis, and multiple sclerosis. You just need to remember that there is a different the pemphigoid group of disorders. Elderly, bullous pemphigoid is in elderly, and it presents with tense blisters. So you can see the blisters are very tense in either lesions. The diagnosis is in a Zang smear. You see plenty of eosinophils. You don't see an acantholytic cell. You will not see because there is no acantholysis. The blister is formed because of separation of the basement membrane zone from the basal cells are separating. The epidermis entire is separating from the dermis. No individual cell is separating. On histopathology, the epidermis is normal. That's why, because the separation is from the base of the epidermis entirely. The subepidermal bulla is filled with fibrin and eosinophils, and the dermis shows infiltrates of eosinophils, mononuclear cells, and neutrophils. I'll show you here. You see, the epidermis is intact. It's just a separation from the top of the dermis. And here you can see a direct immunofluorescence showing linear C3 deposition at the basement membrane zone. Treatment against steroids, again with immunosuppressives. The prognosis is benign self-limiting disease. Mortality rates are very less, and most common cause of death is usually due to underlying associated diseases. A cicatricial pemphigoid is it has many variants, but you remember that the most common variant actually uh, involves the oral cavity and the eyes, and because this is involvement of the subepidermal lesion, that is C3, IgG, fibrinogen, occasional IgM, IgA, anti these molecules, that autoantibodies against against BPA, bullous pemphigoid antigen, but involving predominantly these mucosae, that is eye, mouth. So there is scarring. The sequelae include oropharyngeal adhesions, esophageal strictures, stridor, introital shrinkage, symblephalon, and statue eye. The linear immunofluorescence, you see linear deposition in basement membrane up to 20%. This is indirect immunofluorescence. We perform direct immunofluorescence, and that is where we see 90% of this deposition. Herpes gestationis is an autoimmune blistering disease of young women, and this occurs in pregnancy. It is basically the bullous pemphigoid of pregnancy. And in this case, because antibodies formed during pregnancy, they can pass on across. These antibodies are IgG antibodies, right? They can pass on across the placenta, and when the child is born, the child can have bullous pemphigoid like lesions. But because the antibodies are not being produced by the child, within a week the lesions disappear and no more lesions occur, right? But the mother will keep on having lesions. Post delivery, the lesions improve, right? And there may be recurrence in the subsequent pregnancies. Linear IgA disease, also known as chronic bullous disease of childhood, CBDC, and in case of adults it is called linear IgA disease. So it is characterized by linear deposition of IgA at the basement membrane zone, and the autoantibodies are against BPAG2. The overlap in the clinical presentation of two entities, that is linear IgA disease and CBDC, are presentation is same, but they differ in age at presentation. So peri-orificial and annular lesions are more common in CVDC than in linear IgA disease. So you can see tense bullae, and this is a typical feature of CVDC, that is string of pearl appearance. This particular appearance, they form in annular fashion. So CBDC is an autoimmune subepidermal blistering disease. Onset is around 5 years of age. The similar presentation: first urticarial plaques with pruritus, followed by blistering at the edges. There is spontaneous remission, usually with age, and direct immunofluorescence will show linear IgA at the basement membrane zone. It is IgA related, right? So these are linear IgA diseases. So IgA is seen at the basement membrane zone. At treatment, dapsone is usually effective and may be combined with low dose steroids. Dapsone is a very good drug for this. Within 48 hours, the patient will show improvement. Dermatitis herpetiformis. You must have heard the name of this disease, and it is associated with celiac disease. Now, dermatitis herpetiformis patients can present without celiac disease also. It is not necessary for them to have gluten, because they just need to have gluten sensitivity. They need not have the entire manifestations of celiac disease. Not all patients of gluten sensitivity will have celiac disease, but histopathological changes of celiac disease will be present. So the onset is usually between 20 to 55 years of age, mainly males, and the antigen is gut epithelial antigen. Or the antigen is actually the transglutaminase antigen that is found in the epithelial cells. You may remember the anti-tissue transglutaminase, anti-TTG3, is one of the antibodies formed in dermatitis herpetiformis. The thing is, epitope spreading anti-TTG1, I mean, in dermatitis herpetiformis, but the skin is anti-TTG3. Now there is epitope spreading in all these autoimmune diseases. A pemphigus foliaceus can convert into pemphigus vulgaris also later. Okay, so what happens here is antigen epitope spreading occurs. So antibodies were initially only against this what am I trying to say? Antibodies were originally against only anti-TTG1, but slowly they start forming against anti-TTG3 also. This is when the skin gets involved, which is why the skin involvement is actually later, right? It's not early. The pruritus is first and most predominant symptoms, and there is eruption of grouped erythematous papules and papillovesicles, which are rapidly excoriated because it is pruritic, and the intact vesicles are difficult to demonstrate. Now, it involves characteristically the extensor aspects, the knees, elbows, and oral lesions are common but asymptomatic. The provocation of lesions occurs with iodides. Differential diagnosis, of course, scabies, BP. See, you can see the lesions, extensor surfaces getting involved. Management: gluten-free diet and dapsone. Dapsone gives very quick relief. Again, within 24 to 48 hours, the lesions will stop occurring. Epidermolysis bullosa acquisita. So from the name itself, you can get, you remember epidermolysis bullosa, right? Now, this is epidermolysis bullosa. So the antibodies have to form against somewhere. That is, this is in all the epidermolysis bullosa, the antibodies were forming against something that has to do with the basement membrane zone. So here also the antibody is forming against something that has to do with the basement membrane zone, that is type 7 collagen. It is found in the anchoring fibrils, right? So it is also subepidermal blistering disorder, and these patients present with trauma induced blisters also, just like epidermolysis bullosa, but the difference is the autoantibody against which the disease, the antibody against which the antigen against which the antibodies are formed. It is also a disorder of the elderly, though it can be seen in young patients. The antigen antibody complex causes direct destruction of anchoring filaments, and there may be inflammatory response by a complement system activation in an inflammatory type. This causes the basement membrane zone to split, and there is a subepidermal blisters. So this generally 4 to 6 decade. Now, flaccid blisters over trauma prone areas in the non-inflammatory type. In the inflammatory type, you have tense blisters. In their case, in the non-inflammatory type, you have healing with scarring, melia, and hyperpigmentation. This epidermolysis bullosa acquisita is not a very important disorder for you to know, but you should know that such a disorder exists. Right? Epidermolysis bullosa acquisita. Here you can see there is this is one of the techniques you should know, that is salt splitting. Right here, salt splitting. So if the skin biopsy is subjected to dissolution in 1 molar salt solution, that is table salt, normal salt, NaCl. After 24 hours, the dermis and the epidermis split at the level of lamina lucida. Okay, they split. So if we apply the antibodies now for direct immunofluorescence, depending on where the antibody is sticking, whether on the dermal side or on the epidermal side, we can have an idea against which antibody, the against which antigen, against which molecule the antibody is forming. So you have to know these things, that is direct immunofluorescence, Zank smear, salt split technique, these things. Treatment of EBA is again with IVIG, colchicine, MMF, that is mycophenolate mofetil, azathioprine is also given, methotrexate, cyclosporin. So this is a general approach. Now, as I told you earlier, you have to do a Zank smear as a bedside test, the clinical test, that is bulla spread sign and Nikolsky sign, to look for acantholysis. The nature of the bulla, that is flaccid. These are parts of the examination itself. Nature of the bulla. In the history, you have to ask whether there is rupture of the bulla with trivial trauma. Then there is histopathology and immunofluorescence. Immunofluorescence is one of the important tests. Even if you don't have a histopath right now, if you histopathology, it takes some time, right? It takes maybe a week or two, but immunofluorescence can be gotten 1 to 2 days. Once you have an immunofluorescence, you have a confirmation of the disease. I don't expect you to solve MCQs right now, but after this lecture, if you can tell me the difference between pemphigus and pemphigoid, I'll personally be very happy. Right. Now, Nikolsky sign is commonly negative. I don't think I can't start a survey in this one, but let me just tell you the answers. Nikolsky sign is commonly negative in, the answer should be bullous pemphigoid, because it's a subepidermal disorder. Now, toxic epidermal necrolysis is actually a dicey thing. It has something called a pseudo Nikolsky sign rather than a Nikolsky sign, but here the best answer will be bullous pemphigoid. Right? So if you have a question like this in your NEET PG entrance, you understand, right? The drug of choice in the treatment of DH should be always dapsone, right? It's always dapsone because the response is very quick. Row of tombstone appearance in histopath is seen in pemphigus vulgaris, we discussed initially, that is the basal cells arranged in a layer. Dystrophic epidermolysis bullosa is seen due to mutations in, of course, something that is deep in the sublamina densa, that is type 7 collagen, not laminin 5, not BPAG2. These are laminin 5, BPAG2 are located in the lamina rara and densa. Keratin 5 and 14 causes epidermolysis bullosa superficialis. Senior Usher syndrome is not very important for you. Pemphigus erythematosus, right? So I hope you all are clear about the basic differences between pemphigus, how blistering disorders present, and the basic differences between pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid, linear IgA disease. These are important ones, and dermatitis herpetiformis. I would like you to know these diseases. You can read this from whatever book you prefer. Right. I guess that's the end. I have nothing more to say. Thank you all for joining the lecture. Have a great day.